I just got to get this backed up to where we left off in chapter 11. Sorry, my computer's acting a little slow. We are, whoa, way far behind us. Holy macaroni, where did we leave off? Oh, we did this. Okay, sorry about that. We left off with the cardiac conduction system. So we've talked about the anatomy of the heart, the different chambers of the heart, the major vessels of the heart, and the blood flow through the heart, as well as where the heart is located. So now we're going to talk about how the heart coordinates its contractions. It coordinates its contractions in something called the cardiac cycle. The cardiac cycle is regulated partially by the autonomic nervous system, which you may recall is divided into the sympathetic and parasympathetic divisions, the fight or flight and rest and digest. 1% of cardiac muscle can generate the action potentials over and over and over again. So, as I said, the autonomic nervous system has some influence, but ultimately it's these special conductor cells, this 1% of muscle tissue, that's actually generating the action potentials for that rhythmic contraction pattern. Those special contractile conducting cells control the rate at which the heart beats. They form something called the cardiac conduction system, and it's basically an electrical conduction system within your heart. The autonomic system input is actually reducing the heart rate to about 60 beats per minute. With sympathetic innervation, it can go up to 100 beats per minute, and that's just with the sympathetic and parasympathetic divisions. With the autonomic system input, the heart rate gets to be about 70 beats per minute. So the autonomic system kind of puts the brakes on the natural heartbeat that would be taking place. The electrical activity begins with a location called the sinoatrial node, or SA node. That's also known as the pacemaker. This is located in the right atria, and the signal goes from that SA node to what's called the AV node, or the atrioventricular node. It goes through a special group of fibers called the Purkinje fibers, which protrude into the ventricles, and that allows for the electrical signal to be conducted through all of the muscle tissue of the heart, which enables the heart to have one syncopated contraction. Of course, the intercalated discs are those special cell junctions which allow the transmission of those electrical signals from cardiocyte to cardiocyte. This animation here goes through the cycle of the cardiac conduction system. Let's talk about what an EKG is. Some of you may have even had an EKG. It's basically a record of the electrical charges that go along with the heartbeat. So it's literally recording the action potentials that are creating the electrical currents. And that's, of course, detected by special electrodes that are spaced on certain locations on the chest surface. EKGs are used to analyze various conduction system issues, as well as irregularities in your heartbeat. Cardiologists are the physicians that study the heart and associated diseases with the heart, so they would be the types of doctors that would analyze an EKG. This diagram here goes through the cardiac conduction system as well as an EKG reading. So this diagram of the heart is showing you where the SA and AV node are, as well as those special Purkinje fibers. So if you recall, the conduction is initiated by that pacemaker called the SA node, or sinoatrial node. That's where the impulse begins. It radiates from there, goes to the AV node, or atrioventricular node, which then passes that electrical signal to something called the AV bundle, or atrioventricular bundle. There's right and left bundle branches which go to either ventricle, and from the ventricle they kind of radiate out into those special fibers called Purkinje fibers to innervate through the ventricles. As it does that, that is basically telling the cell when to contract. On this EKG, you can see where the atrial contraction occurs and the ventricular contraction occurs. The atrium ventricles do not contract together. First the atria contract, and then the ventricles contract, as you see here. On this EKG, there are three major wave segments. There's a P wave. The P wave is when the atria are depolarizing and getting ready to contract, and that's what you see right here. Then there's the QRS wave. That QRS wave or QRS complex is the onset of the ventricular contraction. So that's as that depolarization is traveling from the AV node through both ventricles. Then finally the T wave, which is where those ventricles are repolarizing and resetting themselves. And then the P wave starts over again. So between the P wave and the QRS is when the atrials contract, and between that QRS and T is where the ventricles contract. So again, the atria contract before the ventricles, and if you remember that pathway of blood or the flow of blood through the heart, as those atria contract, literally all they're doing is squeezing whatever leftover blood they have in them down into the ventricles. Then when the ventricles contract, they're pumping that blood out into the body via either the lungs or through the systemic circuit via the aorta. This animation here goes through the cardiac cycle and the EKG, which is also known as an ECG. Let's talk about some arrhythmias. Arrhythmias are irregular heart rhythms, and that could be due to a defect in the conduction system. Again, these are all going to be detected through an EKG. In some cases, the SA node can be disrupted for whatever reason. Some of the causes of that SA node disruption could be coronary artery disease, hypertension or high blood pressure, a myocardial infarction, which is a heart attack. Hyperthyroidism can also cause this. Defective heart valves that aren't closing properly. Stress could induce an SA node disruption, as well as drugs and other chemicals that influence the nervous system. There's another condition called supraventricular tachycardia. This is a rapid heartbeat of 160 to 200 beats per minute. It starts in the atria. The episodes begin and end very suddenly, and this can last minutes to hours. Some people experience this and they call it heart palpitations. It's that quick fluttering in your heart that sometimes you feel. There's also a condition called a heart block. This would be the blockage of electrical pathways between the atrium and ventricles. Usually it's a blockage of the AV node. As you can imagine, this would cause a non-continuous contraction within the heart muscle itself. It would cause the heart contractions, particularly in the ventricles, to be very irregular and uncoordinated. Premature ventricular contraction would be an early heartbeat in the ventricular myocardium that's going to interrupt the normal rhythm. This can lead to many experience this as heart pain or chest pain when this is occurring. This shows up very irregularly on an EKG. There's also atrial premature contraction. That would be an early heartbeat in the atrial myocardium, so this is going to interrupt a normal rhythm. There's also atrial flutter, which is again those kind of palpitations that you would feel. This can sometimes come hand in hand with that AV block. With the atrioventricular node being blocked, those electrical signals can't get to the ventricles, so the atria are going to kind of flutter a little bit to get the electrical impulses past that AV node. There's also ventricular tachycardia, which is a rapid heart rhythm that starts within the ventricle and radiates out. Tachycardia is the technical term for rapid heartbeat. There's also atrial fibrillation. That would be an asynchronous contraction of 300 to 600 beats per minute. The atrial contraction stops completely and then starts back up again. There's also ventricular fibrillation, which is asynchronous contractions within the ventricles. This can be treated by passing electrical current through the heart to stop those contractions. So these are the types of maladies that occur that would require someone to use a defibrillator, hence defibrillator being used to block an atrial fibrillation or ventricular fibrillation. The cardiac cycle itself is that cycle between the contractions. It is classified into a series of systole and diastole. Systole is the name for the contraction, and diastole is the relaxation. As you may recall, when the atrial are contracting or when the atrial are in systole, the ventricles are in diastole and vice versa. Diastole is when the chambers are filling with blood. Systole is when the chambers are contracting and emptying the blood. The atria first contract, and then the ventricles contract, as I mentioned earlier. The cardiac cycle lasts less than a second, about 0.8 of a second, so 0.8 of a second is the length that it takes for one heartbeat to occur, one cycle to occur within our heart. The atria contract for about 1/10 of a second and then relax for 7/10 of a second, whereas the ventricles are contracting for a bit longer. It's because they have more myocardium, they're generating more force. They're going to rest for a little bit less time also. They're resting for about 1/2 a second. Both ventricles and atria are relaxing together for about 4/10 of a second. You don't really need to be too concerned with the overall times for this, but you do need to understand when the various atria and ventricles are contracting. So as the heart rate increases, this relaxation time is then shortened. The blood filling into the chambers only takes a shorter amount of time, so pumping volume is still conserved, even though the rate of contraction is sped up. This animation here goes through the cardiac cycle. Let's talk about the heartbeat sounds. In lab, you'll have a chance to use a stethoscope to hear your own heartbeat sounds. They're broken into what's called a lub sound. The lub is the long, booming initial sound, and that is from those AV valves closing. The AV valves being the mitral valve and the tricuspid valve. The dub sound is from the semilunar valves closing, and that's at the end of ventricular systole. So the pause after the dub is due to the relaxation period. So the lub sound, that first sound you hear, are those AV valves shutting, and then the dub is the semilunar valves shutting. This slide here is going through the various steps of the cardiac cycle. We'll start at the top with number 1. We're going to begin in relaxation or diastole. As you see in relaxation or diastole, the ventricles are relaxing. It's called isovolumetrically. So in other words, there's no change in volume. They're not being squeezed. They're repolarizing. This is all on that T wave of the EKG. Blood from the body and the lungs are going to fill the atria. That's a very passive process. It's just the blood's trickling in to fill those atria. When the ventricular pressure falls below the atrial pressure, that's when those AV valves open. Again, that's a passive process. The AV valves just open on their own after the pressure gradient changes. At the end of that phase, the ventricles are about 3/4 of the way full, and then the atria begin to depolarize. That's that squeezing of the sponge, so to speak. Those atria are going to squeeze the blood down into the ventricles, and that's where we get our P wave on our EKG. As that P wave spreads over the atria, they're going to contract and fill, kind of top off those ventricles with the final 25% of the blood needed. Then those AV valves are still open, those semilunar valves are closed. At the end of atrial systole, that's going to mark the end of ventricular relaxation, or the end of ventricular diastole. With ventricular contraction or ventricular systole, the ventricular depolarization is going to begin, and on the EKG, that's that QRS complex. The ventricular fibers are going to contract. They're not going to shorten. It's called an isovolumetric contraction. They're squeezing, they're generating some tension, but they're not changing in length. The volume is staying the same. That's going to cause an increase in ventricular pressure. When the ventricular pressure exceeds the atrial pressure, that's that lub sound. That's those AV valves closing. The ventricular pressure continues to increase, and then when that ventricular pressure exceeds the pressure in the aorta, boom, those semilunar valves open, the ventricles pump the blood out, going through the aorta as well as the pulmonary arteries. Blood's going to leave those ventricles, the ventricular pressure is going to drop, and then those semilunar valves are going to close. That's the dub sound that you hear. The ventricular systole ends, and then you see the T wave on the EKG, which is the repolarization of the ventricles. Overall cardiac output is the term given to the overall work by the heart. That's the volume of blood ejected divided by the beats per minute. So the cardiac output equation is stroke volume by heart rate. Cardiac output in general is equal to the stroke volume, which is usually given in milliliters, times heart rate, which is usually given in beats per minute. So as your stroke volume increases, your heart rate may decrease, which is going to keep your cardiac output the same. Or if your heart rate increases and your stroke volume stays the same, your cardiac output will stay the same. But if your heart rate increases and your stroke volume also increases, that means you're pumping more blood more quickly through the body, which is ultimately going to increase your cardiac output. This animation here goes through the details of cardiac output. There are some various factors that influence stroke volume or heart rate. Some things that influence stroke volume include blood pressure. That the blood pressure specifically at the end of diastole, so at the end of contraction. That's called the preload. The force of contraction is also known as the contractility. It's dictated by what's called the Frank-Starling law of the heart, and this is ultimately going to depend on the degree that the heart has been stretched before it contracts. So the more blood entering during that resting period of diastole, the stronger the contraction is going to be. There's also vascular pressure that has to be overcome in order to push the blood out of the chamber, and that's called afterload. So preload, contractility via the Frank-Starling law, with that heart being stretched, as well as the afterload, are factors that influence stroke volume. Factors that influence heart rate include the autonomic nervous system, which is going to cause an increase in heart rate, or possibly a decrease in heart rate if we're talking parasympathetic. Various hormones such as epinephrine and norepinephrine, as well as levels of ions such as sodium and potassium, which can decrease the heart rate and contractility. Calcium ions are going to increase the heart rate. Body temperature can also increase the heart rate. As the body temperature increases, so does our heart rate. Age can influence our heart rate. Newborns have a higher heart rate than adults do. Gender can also affect your heart rate. Females have a higher resting heart rate than males. Typically, the rule of thumb is smaller people have higher heart rates. So females tend to be smaller than males, so they have a higher heart rate. Newborns are smaller than adults, so they have a higher heart rate. There's also physical fitness. A lower resting heart rate with regular exercise is common. Cardiac output is going to be the same since the heart is enlarged, giving you a larger stroke volume. This is a diagram here going through exactly what I just went through with the regulation of cardiac output. We'll start up here. Autonomic nervous system can change heart rate as well as stroke volume with different receptors receiving input. The baroreceptors within the carotid arteries as well as the baroreceptors in the aorta, sending information to the brain saying the blood pressure is too high or blood pressure is too low. And then, of course, the medulla oblongata regulating those the stroke volume and heart rate. There's a cardiac acceleratory nerves, which are going to increase the heart rate, and the vagus nerve activity is going to slow the heart rate. Vagus, of course, being parasympathetic innervation. There's also factors that are going to affect stroke volume under normal conditions, including that degree of stretch via that Frank-Starling law that I mentioned. The increased blood flow is going to increase the force of contraction as well as increase the stroke volume. Decreased blood flow is going to decrease the contraction force and decrease stroke volume. The force of contraction is going to be increased by increased calcium as well as epinephrine and norepinephrine. Decreased force of contraction is going to decrease stroke volume. Increased levels of sodium and potassium are going to decrease contractility. Decreased body temperature is also going to decrease contractility. Blood pressure is also going to have an effect on our stroke volume. Increased aortic and pulmonary pressures are going to reduce the time that those valves are going to remain open, so that's going to reduce the stroke volume, and decreased pressures are going to have an opposite effect. They're going to increase the amount of time that those valves remain open. This animation here goes through the effects of the autonomic nervous system on the conduction of the heart. We'll stop here.